Thank you so much for the introduction, and thank you for sticking around. I know the conference is winding down and everybody's really tired, so thank you. It's like a nice intimate group, so if you like, because I know the slides are kind of small, scoot up if you like, and I'm going to make this kind of an open discussion presentation, so, and there's a small group of us, so why don't we, if you have any questions, feel free to raise your hand and just interrupt me at, yes, like that.
I just had my fourth radioactive iodine in September.
Yeah.
I had molecular thyroid cancer with metastases to the liver and to several bones. And my last scan on September 29th showed no, everything was the same.
Uh-huh.
But the one in April showed that I had additional liver lesions. So I'm getting a second opinion in Toronto from Edmonton, Alberta.
Okay.
So I've had 650 millicuries in total. So I'm kind of thinking I've probably gone out.
Okay, so we'll discuss that then. So part of the presentation, we're going to talk about avid disease, and when we come to that slide, I'm going to specifically answer that question. Okay, all right, so like I said, yeah, feel free if there's any questions or you need any clarifications, just stop me at any time while we're doing the presentation, and I'll be very, very happy to answer your questions. Like I said, yeah, scoot up front, it's not a big group here, so you can see the slides. All right, so this is a topic, so I know that the title of my slide here is different from what's in your handouts. The reason being is that initially I was going to just talk about the treatment of metastatic thyroid cancer with radioactive iodine, but then I was asked to present kind of on this topic, which is a little bit more broad, and basically it's just kind of using radioactive iodine in general to treat patients with known metastatic cancer and patients without metastatic cancer. It is a controversial topic. I'm going to try to present this in a non-biased manner because, all the physicians have their own opinions and kind of what they want to do. But I'm going to present to you what's out in the literature, hopefully in a non-biased fashion, and it's helpful to you all. All right? I have no disclosures. So in terms of the outline, the first thing I'm going to talk about is just kind of a brief introduction of iodine and what is radioactive iodine and how it's used in thyroid cancer. And then we'll talk specifically about two different topics. So the first topic is going to be I-131 therapy, but it's going to be I-131 ablation, and then versus I-131 treatment, which is reserved for recurrent and or metastatic thyroid cancer. So in terms of iodine, you guys all probably know better than I do, there's a lot of foods that contain iodine. And iodine is an essential nutrient or mineral that we need to obtain from our diet because our bodies do not make it. In terms of the foods that have a lot of iodine, seafood, any sort of vegetables that's grown in iodine-rich soil. For a long time, and it's still in parts of the world, there's iodine deficiency. But what happened here in the U.S. is around 1940s, the government said, okay, we're going to start adding iodine to table salt. So now actually a lot of people get too much iodine, I think, in some ways, if you eat a lot of salt, because the salt actually has added iodine to it. And I'm sure many of you guys know better than I do how difficult or how many foods actually have iodine in it when you actually start following the low iodine diet. Can you raise your hands? Yes. And the biggest question I always get when I talk to patients, when I do the consultation for the treatment is, so how long do I need to be on this diet for? So, so that's iodine here. So in terms of iodine and thyroid hormone, iodine is very essential. You have to have iodine for your thyroid gland to make thyroid hormone. And we know that thyroid hormone is very important. It starts basically at conception. So thyroid hormone is very important for brain development, fetal and infant brain development and body growth. And in adults like ourselves, it's very important for metabolism. It actually affects pretty much your many organ systems, some major ones being your heart, your cardiovascular system, as well as your bones. But it actually affects pretty much everything in the body. So it's very, very important. So then now that we talked about iodine, what is I-131 or radioactive iodine? So I-127, I have a little picture here of the periodic table. Basically, let me see if this works here. Okay. So I drew a little picture of the periodic table. I-127, this is the non-radioactive iodine that we get from our diet. But then there are actually many different forms of iodine, and some of the different forms of iodine are radioactive. So the example we're going to be using here is I-131, and I-131 is a radioactive form of iodine that we can actually use to treat patients for thyroid cancer. You can also use it to actually just take pictures or get images of thyroid disorders as well. And I drew a little picture, and I usually go into kind of a description of this with my patients when we do the consultations. And basically, it's basically the same thing, but I drew a little picture of the atom here. And in the middle of the atom, we have what we call the nucleus. The nucleus is composed of protons and neutrons. And basically, there's a different number of neutrons, and that's what makes the different types of iodine. And it's also what makes some of the iodine radioactive. So in the case of radioactive I-131, there's a lot of neutrons, makes it radioactive. It actually gives off two different types of radiation. So we have what we call beta radiation. Beta radiation moves very, very short distances, about 1 to 2 millimeters. So it's a very short distance. And that's the radiation that actually is able to kill thyroid cancer cells as well as destroy normal thyroid tissue. And then in addition, we also have what we call gamma radiation, and that travels farther from the body, about 3 to 6 feet. And that's the reason when we have patients have the radioactive iodine treatment, we give you instructions about, well, you need to stay at home, you need to maintain about 3 to 6 feet distance from people, and that's because of the gamma radiation component. Now, the gamma radiation component, on the other hand, is what allows us to take pictures of your, of the body after radioactive treatment to kind of screen the rest of the body. Now let's talk about using radioactive I-131 for thyroid cancer. This has been in use for about 70 years, so for a very long time. It was first reported in the literature back in 1946, and it was actually used for a patient with metastatic thyroid cancer. In terms of treating thyroid cancer with radioactive iodine, usually we do it for cancers that are papillary and follicular thyroid cancer. The key is this. The thyroid cancer has to take up the iodine or the radioactive iodine in order for us to use it for our patients. There are exceptions, and some of the exceptions include cancers like medullary thyroid cancer, anaplastic thyroid cancer, and poorly differentiated thyroid cancers. And these last two cancers here, the anaplastic thyroid cancer and poorly differentiated thyroid cancers, those are usually what we describe as cancers that probably used to take up the radioactive iodine, but as the disease has gotten more aggressive, it's lost that ability to take the radioactive iodine. So unfortunately, in patients who have these types of cancers, we're not able to use radioactive iodine for treatments. Now I have a picture here. So they usually come like this. They come in, this little blue thing here is actually this big heavy lead. We call it a lead pig. And you open it up, and then the capsules are in there right here. So this is the radioactive iodine. I like this picture here. Actually, I got this picture from a website. There was a patient who actually had their own blog and kind of documented their entire experience for treatment with radioactive iodine. So actually they had, I guess, their partner bring a camera, and they took pictures during the actual treatment itself. So that was pretty neat. So this actually is a picture of this patient getting the radioactive iodine here. Now, when I'm talk about radioactive iodine or I-131 therapy, there's two different, we kind of distinguish into two different types, and I want to make that clear right from the start right here. So when you talk about treatment with radioactive iodine, you can kind of broadly classify it into kind of two types. The first you would call what we call I-131 ablation, and I'm going to go into details of what the differences are. And then number two is actual terminology would be I-131 treatment. So ablation and treatment, in both cases you use radioactive iodine, but you have a different therapy purpose for those two different types of therapy. So we're going to discuss that. So what is I-131 ablation? So in general, what that means is I-131 ablation is for patients, and it's their very first time treatment with radioactive iodine. And these are patients who have no known spread of cancer beyond their thyroid gland. So in these patients, it's done after surgery, after a near total thyroidectomy, so you get the thyroid gland out. And really the primary goal of treating patients with I-131 ablation is that you're trying to ablate or destroy any remaining thyroid tissue. Most oftentimes, it's not going to be cancer because these patients had very small cancers to begin with. But what it does is it gets rid of any remaining residual normal thyroid tissue. And if there was thyroid cancer in that area and it took up radioactive iodine, it would also treat that as well. But that's what we mean when we say I-131 ablation. Okay? And usually these patients get much lower doses than the other patients who are in the I-131 treatment group. So I-131 treatment refers to using radioactive iodine in patients who unfortunately have spread of the thyroid cancer to other parts of the body, or maybe you were already treated and it has come back. In those patients, we would say we were doing an I-131 treatment. And same thing, it's done after surgery. But the primary goal when we do actually I-131 treatment is to destroy thyroid cancer that has spread beyond the, spread to other parts of the body and or has come back from a prior treatment. So, and these patients are going to get much higher doses of radioactive iodine because we're treating for a different purpose. So I'm going to start by talking about I-131 ablation. So these are the patients. This is going to be usually their very first time being treated with radioactive iodine. The goal being we're trying to just get rid of any remaining thyroid tissue. So this area, actually, there's been a lot of research going on, and things are changing, actually, quite a bit in terms of how physicians are viewing who needs to get radioactive iodine ablation, who does it benefit, and who does not. So I'm going to kind of just touch on those topics here. So this is a controversial topic. So let's talk about why would we want to do radioactive iodine treatment in patients after their surgeries remove the thyroid cancer. So some of the benefits of I-131 ablation, number one, it may help to detect unknown spread of thyroid cancer to other parts of the body. So, before the patients get the treatment, basically you've already had the thyroid surgery, I'm sure you've already had, some sort of scan, and they didn't detect that there's any spread of thyroid cancer. But after you do this treatment, because the radioactive iodine will go to any sort of thyroid tissue, whether it's normal thyroid tissue or thyroid cancer cells, we can instantly detect. They say usually about 10 to 20% of patients may actually have metastatic disease, cancer that has gone to other parts of the body that they didn't know going into surgery. So you could actually detect that. And so here's a picture. So this is a patient who came back about 7 days after they had their I-131 ablation treatment. So the patient had surgery, and then about 3 months later, they came to us. We treated them with about 30 millicuries of radioactive iodine, the ablation dose. And then a week later, after you do the safety precautions at home, and then you come back a week later, we just take pictures. No more radioactive iodine, we're just taking pictures. So I'm going to explain to you what the pictures look like. And this is what most of our patients look like when they get their pictures done after they have their radioactive iodine treatment for the very first time. So it's really hard to see because basically most of the radioactive iodine is pretty much gone from the body by this point when you're 7 to 10 days out. And so let me point out what we're seeing here. So this actually is an entire body scan here. And here at the top, you see these 2 dots. Those are the salivary glands. And I'm sure you're aware of the fact that iodine, radioactive iodine, naturally will go to the salivary glands, and that's what we're seeing here. So that's normal uptake in the salivary glands. And then you see this dot right here, right in the middle, that's nice and hot. That's going to be residual thyroid tissue from where the surgeons took out the thyroid glands. So the surgeons do an excellent job of taking out the thyroid gland, but there's going to be tiny bits of thyroid gland left, which are going to be impossible to see with the naked eye. But what happens is when you do this treatment, we see that we know there's residual thyroid tissue left, because this is what we see. Right in the midline where the thyroid gland used to be, we see some uptake of the radioactive iodine. So this is normal. We expect to see this in a patient who had thyroid surgery, basically residual thyroid tissue. And sometimes you can see a little bit of uptake in the liver or maybe in the bladder, and that's normal. Okay, that's just kind of normal excretion of the radioactive iodine. So in addition to taking this whole body picture, what we also do is what we call a transmission image. And this is to help us kind of figure out the body contours better, because as you can see, because most of the radioactive iodine has washed out from the body, it's really difficult for us to figure out what exactly is what. So we'll also do a transmission, which gives us an idea. Okay, here's the head, so we know that's the salivary glands, and this is the neck, and then we have a little marker here, and we can see the lungs and the heart. So we also do this kind of outline picture of the body to help us as well. So what's a second benefit of doing a radioactive I-131 ablation? So when we so we talked about the fact that mainly it's done to destroy any normal thyroid tissue that's left in the thyroidectomy bed, but also it can destroy any residual thyroid cancer that is left, because radioactive iodine will go into both the thyroid cancer cells as well as normal thyroid tissue. And theoretically, the reason why they think this is good is because this may potentially decrease the risk that the patient will have recurrent thyroid cancer in the future, okay? So at this point, I'm going to talk about the fact that, so back in about 1994, there was a paper that came out. It was a retrospective study, which means they looked back at some data that was collected, and this paper actually described the fact that they thought it looked like, from the pattern of what they were seeing, that patients who got treated with radioactive iodine after their thyroid surgery actually did better, as in they had longer survival, they had less risk of recurrence. And when that paper came out back in the mid-90s, that actually spurred on the movement, and a lot of people actually started, a lot of endocrinologists and oncologists started prescribing radioactive iodine for patients after thyroid cancer surgery. And that kind of is what's prompted that. But since then, especially like around 2005 to 2010, there's been other papers that came out which actually describe the fact that potentially maybe it's not beneficial for patients with the lowest risk of cancer. And I'm going to actually describe that in detail, but since I'm talking about this, I wanted to mention that. Now, what's the other benefit of I-131 ablation? Well, the goal is that by getting rid of any residual thyroid tissue, that it's going to help with surveillance for future thyroid cancer recurrence. And it will assist in blood, you can actually do blood tests to detect if there's any rise in thyroglobulin levels, which would be an indicator that maybe the thyroid cancer has come back. And also, you can actually survey for any recurrence thyroid cancer by doing whole body I-123 or I-131 scans. And that actually also helps when you get rid of any of the normal thyroid tissue. The idea is that if you have any residual normal thyroid tissue, it's going to continue to produce thyroglobulin. So your thyroglobulin levels are not going to go to undetectable if you have residual thyroid tissue. So I-131 ablation would get rid of that so that screening with thyroglobulin would be more sensitive. Yes?
It's my understanding that some of the thyroid cancer cells stop producing thyroglobulin. So in follow-up after years, how do you know if there's thyroid cancer there, if your thyroglobulin isn't going up?
So what you're describing to me is that as thyroid cancer potentially becomes more aggressive, it loses its normal function as a thyroid cell, which includes making thyroglobulin. So in patients potentially who have undifferentiated thyroid cancer, what's going to happen is it no longer acts like a normal thyroid cell, so it stops making thyroglobulin. In which case, basically what we'd have to do is, one of the things you could do is you actually try to do an I-123 scan and see, because in that case, because the thyroglobulin is no longer helpful, you'll see, well, maybe it still maybe at least picks up radioactive iodine. So one of the things that the doctors can do is order a I-123 scan and see, is there still any sort of cancer in the body that actually takes up radioactive iodine? Because as I described, once you've had the thyroid surgery and you have the ablation, you really shouldn't have any uptake of radioactive iodine, except for in the normal places that you expect, like salivary glands, stomach, and bowel, and things like that. Yes. Oh, I'm sorry. Let me finish your question. All right. So, so that's something you can do. But unfortunately, what can also happen is as the thyroid cancer becomes more aggressive, in addition, it may actually lose the ability to take up radioactive iodine, in which case an imaging study that can be done is what we call a FDG PET scan. And the PET scan actually, we use a radio tracer. We inject this radio tracer into the patients, and it's basically like glucose or sugar that your body uses. And the idea is that cancer cells are more metabolically active, more active than your normal cells. And if you see abnormal spots on the body when you do an FDG PET scan, that can help also detect for recurrence of cancer. So those are kind of some of the strategies that you use when thyroglobulin unfortunately becomes no longer helpful in establishing recurrence of thyroid cancer. Yes, your question. Oh, okay, all right, okay, all right. So here's an example of a patient. So this patient had kind of intermediate to high risk for recurrence. And one of the things that they did was that because I think the thyroglobulin level was not dropping as expected, this patient actually got a follow-up I-123 whole body scan. Not all patients are going to get this scan because in general, if your thyroglobulin levels drop low and are undetectable, They can actually just follow using the blood test. But sometimes, blood tests may not be helpful or what have you. Then in that case, you can actually do an imaging study. Yes? Oh, in terms of the thyroglobulin levels? It's going to be both. They're going to look at both. But usually if you have it under suppression, if it's very undetectable, there's really no reasons to stimulate it usually. So what they do is right after surgery, they measure kind of a baseline thyroglobulin level. And they expect to see that to actually even further decrease after you do the I-131 ablation. So that's kind of what they're looking for. And if they don't see that, then they actually may order this I-123 scan to kind of take another look to see, what's going on. Is there evidence for recurrence or some sort of residual thyroid cancer with this scan? Does that answer your question? Okay, perfect. Okay, so here is an example of a patient who had a whole body I-123 scan about a year after she had her surgery and the I-131 ablation therapy. And this actually is a normal scan. And most of the times, this is what we see in our patients here. So let me describe to you all, but then you're like, but there's all these dots and black spots everywhere. So what does this mean? So I'm going to describe to you. This actually is just all normal physiologic distribution of radioactive iodine. So here in the head, you can see that in this patient. So I-123 is a different form of I-130 than I-131 in terms of radioactive iodine. The reason is I kind of talked about earlier how there's two types of radiation. You have the beta radiation, which travels very short distances, about 1 to 2 millimeters. That radiation is, you can say has more energy and it has the ability to actually destroy tissue. Now, I-123 is a form of radioactive iodine that does not have beta radiation. So it doesn't actually destroy any tissue or anything like that. It only has what we call gamma radiation, which is the one that travels further from your body. And that helps us to take pictures after the radio tracer is administered. So this I-123 is just for imaging, not for treatment. So this patient here, as you can see, you can actually kind of make out the body contours here. Here's the head, this is the neck, torso, and then bottom of the body up to the knee here. It's normal for us to see uptake in the salivary glands. And then you can also have uptake in the nasal secretions, and that's what you're seeing right here. Sometimes there's a little bit of the uptake here that's linear in what we call the midline of the chest. And that's because you're swallowing saliva that may have small amounts of radioactivity. And so we see that, and that's normal. It's normal to have activity in the stomach. I'm not going to go into the details, but one of the transporters that's involved with taking up iodine, that transporter actually is also in the stomach as well, so that's why you're seeing that. Also, when you're swallowing secretions, it goes to the stomach, and that's why you see that. So this is normal activity. And then because you have normal activity being secreted into the stomach, what happens is you'll also see small amounts of it in the stool, in the colon, so this is normal. And then, of course, the main route of excretion of how it's gotten rid of from the body is through urine. So you're going to see normal activity in the urine. So all the activity that we're seeing here in this patient actually is all normal. So this patient has a good prognosis here. We have no evidence for recurrence of thyroid cancer on this follow-up radioactive iodine scan done on this patient. So now that I've talked about kind of the reasons of why, or the benefits of why we would do an I-131 ablation therapy, let's talk about potential complications. Because it's true, radioactive iodine, pretty much all drugs have some sort of side effects or complications. So I'm going to go over some of the more common ones here, and the ones that are actually discussed in detail with my patients before we do the treatment. So number one, we always talk about the fact that initially, within hours to a couple of days after the treatments, patient may have some sort of GI discomfort. Most often, patients describe nausea, vomiting, sometimes diarrhea, but really more nausea and vomiting. Another complication or potential side effect is going to be salivary gland dysfunction. And I tell patients, you may experience, dry mouth, or food tastes a little bit funny, or you may actually even have some pain in your salivary gland region because of the radioactive iodine just normally going to that area. About a week or so out is when sometimes patients will describe, tear duct obstruction. So you've got kind of the watering of the eyes, and that's because normal small amounts of the radioactive iodine will go to the tear duct area. Temporarily reduced fertility. So this, there's really no increased risk for any sort of impaired fertility in the future. But we do know that after radioactive iodine treatment, patients, both male and female, will have reduced levels of fertility. We know that there are decreases in sperm counts for men, and in women, maybe the ovary's not functioning as well. But in general, most patients actually recover. And that's why when I tell patients after treatment, whether it's for thyroid cancer or for Graves' disease or hyperthyroidism, we just say, you should wait about 6 to 12 months after treatment to try to get pregnant. Okay. And then the biggest, I think, complication that people worry about is, since I'm getting this radioactive medicine, is this going to cause cancer in the future? And yes, there is potentially increased risk of secondary cancers, but I want to emphasize here that it's a very small increased risk for secondary cancers. And then what are the secondary cancers that may occur? Most commonly, it may be related to salivary glands, because the radioactive iodine goes to the salivary glands, so you may get salivary gland tumors. And then we also say leukemia, because if amounts of it go to the bone marrow, it could actually potentially cause leukemia. But really, I tell it's a less than 1% chance. Now, as your cumulative dose of radioactive iodine increases, so let's say you have recurrent metastatic cancer that's detected, and you get treated with multiple doses of radioactive I-131, as that dose level increases, your chances of getting secondary cancers will also theoretically increase as well. But still, it's not a huge increase in terms of, oh my goodness, I have a 50%, it's still a very, very small increase. Now, at this point, I want to point out the fact that all these, kind of potential complications with radioactive I-131 that I've talked about, they actually are more likely to occur with increasing doses of I-131 that you receive. So at this point, I think this will be interesting for me to kind of do a survey of the room. So could you raise your hand if you've had treatment with radioactive I-131? Which I assume is pretty much most people. Yes. How many people had actually one of these symptoms? Okay. All right. Now, can somebody call out what are the symptoms that you ended up having? Right after you swallow the pill, or okay. 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 And for you, was it temporary, or so it did go?
Mine's permanent right now.
Okay.
My blood counts have gone down, my hemoglobin.
Okay. Okay. Anybody else? Yes.
I had severe nausea.
You did. Okay.
Nobody told me I could expect. Everyone said, "Oh, this is a non-effect."
Okay.
And it went on for 3 or 4 days.
And that was right after your treatment?
It wasn't right after I took the pill, but the next day.
Okay. Okay. Anybody else? Yes. Okay. Okay. So let me get a Okay. So, it's very much dosage related. So higher dosages are more likely to cause these symptoms. In general, with the nausea, most patients that we see who get the nausea are patients who get about 100 or actually over 150 millicuries. So these are patients who have no metastatic thyroid cancer usually. But we do have patients who get nausea and vomiting with lesser doses than that. And in terms of the salivary gland dysfunction, I feel like, patients get it. Usually patients who get over 30 millicuries will get that. But in general, it's usually temporary. But the higher levels that you get and more repeated treatments you're going to get, that may actually become permanent. So the patients who've had the side effects, can you tell me, did anybody get less than 50 millicuries and had that side effect? No. Okay. So patients who've had the symptoms over 100 millicuries, and that's why. Okay. 200. Yeah. 200. And how about yourself? Yeah.
We had hundreds of people through there in the last 10 years, and the only ones I know that have come through that have what I had over 200 or more.
Okay. Yeah. Yeah. Everybody's body acts different. Everybody's different. But yeah, in general, the higher doses are going to cause some of the symptoms. And in terms of the symptoms being temporary or permanent, the repeated treatments that you get can actually make the symptoms less likely to be temporary and more permanent. So yeah, it's not without its complications. But at the same time, I want to say, that for most patients, when you get less than 100, really all these symptoms may or may not happen. and oftentimes it's going to be temporary. Okay? All right. So here's the first kind of controversial question. Should all patients get radioactive iodine after they have their thyroids removed for thyroid cancer? And the answer is, so it used to be that people are like, oh yeah, why not? We saw this study, everybody seemed to do better after they got radioactive iodine versus not getting radioactive iodine. So, it used to be very standard that everybody got some form of radioactive iodine. But actually that thinking is actually changing now that we have more information and more data. And so now we know that not all patients may actually benefit from getting radioactive iodine therapy. Okay? So let's talk about that. So who should receive I-131 after surgery? And this is it's a complex question. And some of the factors that affect the decision of whether a patient should receive I-131 include tumor size. So after they take out the thyroid gland, they look to see what exactly is the size of the tumor. Not only that, but they'll take a look at the tumor itself and try to figure out what type, because there are different subtypes of thyroid cancer, and some are a little bit more aggressive than others. So they'll have to look at that. What is a subtype of this cancer that was taken out? They'll also look at patient's age. They know that age is a prognosticating factor, so patients over the age of 45, they get a little bit more concerned about. They also look to see, did the thyroid cancer just stay inside the thyroid gland, or did any of it actually go outside of the thyroid glands? They'll also look to see, because when they do the surgery, they also take out lymph nodes, and they'll look at the lymph nodes. Were there any lymph nodes that showed signs of thyroid cancer? And of course, the other consideration is going to be, at the time of diagnosis, do we see any spread of thyroid cancer to other parts of the body outside of the neck? So those are some of the major factors that go into figuring out whether this patient could benefit from I-131 or not. So then let's talk about who should not get I-131. Really, the only absolute contraindications for receiving radioactive iodine are really in females. If you're pregnant or if you're actively breastfeeding, I-131 is completely contraindicated. The reason being, the baby will actually take up radioactive iodine as well, and so we don't want to have any sort of side effects for the baby, whether the woman is pregnant or actively breastfeeding. And when you're breastfeeding, it actually is excreted in the breast milk, but not only that, normally small amounts of iodine do go to the breast tissues, and when patients are lactating and breastfeeding, there's high amounts of it that go to the breast tissue, and we want to minimize any sort of breast radiation because, there's theoretical risk for breast cancer. So those are the reasons why it's absolutely contraindicated in pregnant women and in women who are breastfeeding. So then let's just talk about, so we talked about absolute contraindications, but who are the patients who actually may not benefit from I-131 ablation and may actually kind of skip it? So I'm going to refer to the 2009 American Thyroid Association guidelines. Now the new guidelines are actually coming out. We don't know if it's going to be late this year, so it's going to be either 2014, but they think it's probably going to be early 2015 when the new guidelines come out. The guidelines actually, I went to a meeting yesterday, and they actually have many more recommendations, and they've actually also changed recommendations. So we'll hopefully get to see that very soon. And basically, since the guidelines that we have available right now are the 2000 guidelines, and the 2009 guidelines, they state that radioactive iodine ablation, so we're talking about not patients with metastatic thyroid cancer, but patients immediately after surgery who have no known spread of the cancer to other parts of the body. Radioactive iodine ablation is not recommended if you have what we call a microcarcinoma. So that means you have a very, very, very tiny thyroid cancer, less than 1 centimeter in size. So if you have a single one tumor, so I drew a little picture here with the yellow dot here. If you have one tumor, that's less than 1 centimeter, or you may actually have multiple, because sometimes what happens is, we take out the thyroid gland and start looking at everything. Oh, there's actually 3 or 4. But if they're all less than 1 centimeter, you'd qualify. In addition to that, we talked about those other factors that we consider when we decide whether the patient needs radioactive iodine or not. So you also cannot have, so your cancer is less than 1 centimeter, and you don't have any high-risk features. So what are some of the high-risk features? Some of the ones are neck lymph nodes that demonstrate cancer. There's a caveat to that, so I'm going to address that. If your cancer actually ends up being a little bit more of the aggressive, more concerning type, you probably wouldn't qualify. And if there's extension of the tumor, even if it's small, outside of the thyroid gland, then it probably is not recommend that you skip iodine. And also, if there's any evidence when they look under the microscope that some of the cancer has gone into the blood vessels within the thyroid gland, then you worry it may have spread to the other parts of the body. So then they would recommend that you do not skip I-131 ablation. But what I'm mentioning is that there are patients, if you are the lucky ones and you have very, very tiny microcarcinoma with no evidence for spread, then I-131 ablation may actually not be all that beneficial, and your physician may say, maybe you don't need this treatment, okay? So then let's talk about other patients. So who else may not benefit from I-131 ablation? So now there's actually increasing evidence that there's a classification now of low-risk patients just may not benefit from I-131 ablation. Now the definition of low-risk patient that is going to be addressed more clearly in the new guidelines. But in general, low-risk patients are, like I said, patients who have smaller thyroid cancers, and they think that it may be, it depending on age. For example, some of the papers suggest that if you're less than 45 years old, even if your cancer is 3 centimeters, but it's less than 4 centimeters, and there's no evidence for spread elsewhere in the body, that potentially all you may need is a thyroidectomy, not I-131 ablation. Now, if you're over the age of 45, because you're at a higher risk group, they may recommend it, even if your cancer is just 2 centimeters. So now they're actually, the size of the actual initial tumor is changing. And also, initially I mentioned that one of the higher risk features that they described before was that if you have any neck lymph nodes near the thyroid gland that have evidence for thyroid cancer, that usually we used to automatically treat with radioactive iodine. Now they're saying, well, maybe not necessarily, because you have a tiny little dot of cancer in one of the lymph nodes. That actually may mean that you may not necessarily need radioactive iodine. So really, this definition of who needs treatment and who doesn't actually is changing, because now they're doing these follow-up studies and realizing some of these patients who have low-risk thyroid cancer may actually not need radioactive iodine. So that is a big change. Now, this is another good question. So let's say they decide that you do need radioactive iodine for ablation. So now we're still talking about ablation, not treatment for metastatic cancer. If you do need ablation, how much do you need? So this is actually ALARA. So this is a term that we like to use in radiology. I'm a radiologist as well as a nuclear medicine physician. And ALARA stands for as low as reasonably achievable. And basically the idea is that, yes, we decided that you need radioactive iodine, but we want to give you as low dose as possible. Because as we saw in the audience, there is side effects associated with giving radioactive iodine. So we want to give you as low as possible. Now, in terms of how much patients have been getting for ablation dose, really, it ranged anywhere between 30 to 100 millicuries, so there's a big range. Okay, a lot of the patients, when I was in training about 5 years ago, a lot of patients that I saw, if they have very, very low risk, they ended up getting like 50 to 75. If maybe like one tiny lymph node was involved, they would give 100. But there was a huge range between 30 to 100 millicuries. But then there are studies coming out, retrospective studies again, basically looking back at data, which said, wait a second. Actually, maybe instead of giving patients closer to 100, 30 millicurie might be just as good for ablating the remnant thyroid tissue. And in 2012, two very large prospective. So prospective study is what we in medicine would consider a better study, because basically instead of just looking back at data, they actually designed the study and they accrue patients, and you do it, kind of prospectively. So it's what we would consider a better research study. So in 2012, data from two large prospective studies came out. And basically, one of the main points that came out of that research study was that in actuality, when you have patients with low-risk thyroid cancer who still need ablation, 30 millicuries may be just as good as giving them 100 millicuries. And of course, 30 millicuries would be better, because the chances of the patient having any sort of side effects is going to be less than 100 millicuries. So these two studies actually came out. And since then, really people have been moving towards, well, if you need radioactive iodine after your surgery, now they're tending towards giving lower doses closer to 30 millicuries versus giving the higher doses which patients were getting before. Now, I will mention that the paper did mention that longer follow-up studies are needed. The reason is this. So when we say, what is the definition of a successful ablation? The way they determined it with both of these studies is the patients came back about 6 to 10 months after they got their radioactive iodine, and they measured the patient's thyroglobulin levels if it was possible. But if it was not possible to measure the thyroglobulin levels, they did a whole body scan. and that's what they looked at to determine whether the remnant thyroid tissue was successfully ablated or destroyed. But this doesn't actually describe whether there was less or increased or about the same risk of recurrence of thyroid cancer. So I think what they're going to probably end up doing is going back to these patients, following them up in 5 years, in 10 years to see, is there any difference in the rate of recurrence of thyroid cancer in patients who got a lower 30 millicurie ablation dose versus patients who got a 100 millicurie dose? That's why I say longer follow-up studies are needed. Because yes, you can successfully get rid of the thyroid tissue with a lower dose, which is great because that's the goal for I-131 ablation, but it doesn't necessarily tell you that the patients who get a 30 millicurie dose do better overall than patients who get a higher dose. Now, having said that, there is retrospective study data out there that says actually patients who got 30 millicurie dose seem to do better seem to do just as well as patients who got higher dose. So there is data out there saying that potentially, that what we're going to see with a future study like this is that whether you got a 30 or 100, you did just as well. But like I said, that data is going to be pending. Okay. All right. So the key thing about figuring out, whether a patient needs remnant I-131 radioactive iodine ablation and how much they need really is going to be accurate risk assessment. And that's actually a big point that all the physicians are focusing on now is accurate risk assessment. How do we accurately classify patients as low risk so that we can be more conservative about management versus being more aggressive about management because the patients are higher risk. So that's kind of the big point that people are working on, and I think there's going to be much more direction with the new guidelines that are coming out in terms of accurate risk assessment, of properly putting patients into categories, allowing them to have more conservative treatment. So that's kind of key. And basically this table is just kind of how they defined low risk versus intermediate risk versus high risk in the 2009 guidelines. All right, so now we're going to switch gears from talking about I-131 ablation to I-131 treatment. And I want to remind you that I-131 treatment is a terminology used to refer to patients who are getting radioactive iodine because unfortunately, they had spread of the cancer to other parts of the body. So should all patients who have metastatic thyroid cancer, meaning that it's spread to other parts of the body, get I-131 therapy? And the answer is usually yes. The only cases where you wouldn't is for whatever reason that cancer that has spread to the other parts of the body. If it no longer takes up radioactive iodine, then it's useless, right? So you wouldn't want to give patients I-131 treatment. But as long as there's evidence that the cancer that spread to the other parts of the body still take up radioactive iodine, then these patients will get treated with radioactive iodine. So here's an example here. This is a patient. This patient had an I-123 diagnostic imaging scan. So this is a type of radioactive iodine that you use for just taking pictures, not to treat. And unfortunately, this is a very young patient, about, I want to say, around 30 years old, who clearly has evidence of metastatic thyroid cancer. And this is after they had their initial treatment a couple of years before with thyroidectomy and ablation. So let me just kind of describe to you what the picture is showing. So you've got the normal uptake here in the head area, in the nasal secretions and mouth and the salivary glands, but you see all this stuff here. These are all the neck lymph nodes that are enlarged and taking up radioactive iodine compatible with metastatic disease in their lymph nodes in the neck. But then, and also when you look at the lungs should be nice and clear and there should be no radioactivity. And this patient actually has kind of this mild diffuse uptake. That's because they had tiny little lung nodules, which were metastatic thyroid cancer in the lungs. But besides that, there was no evidence for bone mets. And then the stomach uptake is normal, and so is the bladder activity here. Yes?
In a patient like this, in the 6-week postoperative thyroglobulin test, would she have had an elevated TG, or would this have been?
So this patient is a patient who presented, I think, about 2 to 3 years after the initial treatment. And the reason the scan was ordered was because the thyroglobulin was concerningly rising. Yeah. So this is a recurrence that occurred a couple of years after the initial treatment. Yeah. So in this patient, we know that because the metastatic disease, including the lung nodules and the nodes in the neck, are taking up iodine, this is a patient who we would treat with radioactive iodine, I-131. Now, if patients have just one single metastatic disease, they wouldn't get radioactive iodine per se. Basically, if it's surgically removable because you have a single focus somewhere where they can actually take it out, the preference is going to be to take the metastatic disease out with surgery. But when you have something like this is not surgically possible to kind of get rid of all the cancer, so you want to get treated with radioactive iodine. So then the question arises. Okay, so we've determined that unfortunately the cancer has spread to other parts of the body, but the good news is the cancer still takes up radioactive iodine, so the patient can be treated with radioactive iodine. Now, how do we decide how much high-dose radioactive iodine we're going to give the patients? And it depends. All right, so right now there are kind of two general types of way we figure out how much radioactive iodine to give to the patients who have no metastatic thyroid cancer that still takes up radioactive iodine. You have what we call empiric dosage, and we also have what we call dosimetry-based dosage. And I'm going to go into details of what each one of them are. Which is better? Well, I have my own bias, and you'll probably see what my bias is, but currently, I'm going to lay it out here. There is no good prospective clinical trial demonstrating that either one is better. Okay, so there's no data out there that says one is better than the other. Of course, I'll make my case for mine, but I'm going to describe to you both methods. All right, so let's talk about empiric dosage. So what is empiric dosage? Empiric dosage is when we decide, okay, based on the pattern of spread of cancer, we say, is it just in the neck nodes? Has it gone to other parts of the body? Do the other parts of the body include disease in the lungs? Okay, depending on that, we put patients to categories of how much radioactive iodine we give them. But it's a fixed dose because patient A and patient B both have cancer that's gone to just the neck nodes. We're just going to give them pretty much the same dose because we put them into the category of, well, there's neck lymph nodes with cancer. If patient A and B both have, lung mets, then we're going to do the same thing. We're going to say, okay, they have lung mets, we're going to put them in that category and give them this kind of same dose, basically. So that's called empiric dosage. So here I put an example. Everybody uses a slightly different variation of this, kind of fixed empiric dosage ranges, but this is kind of a good representation of what we've been doing, which is when patients have just no metastatic cancer that's in the neck nodes, about 100 to 150 millicuries. If patients have lung nodules, anywhere between about 150 to 200 millicuries. And the reason for that is when you have radioactivity in the lungs with I-131, there is a risk that it can cause lung damage. So we don't want to give those patients as high of a dose, so they'll get 150 to 200. But if there's evidence that it's spread to other parts of the body, not in the lungs, let's see in the bones or other parts of the body, the patients may receive anywhere between 200 or 250 plus millicuries. So this is, yes?
Single dose?
Single dose. Yeah.
Is
Yes.
this for both the treatment and ablation?
No. So now we've switched gear. We're talking just about patients who have metastatic thyroid cancer now. Yeah.
So this is for like a year later or 2 years later?
If unfortunately this cancer has spread to other parts of the body, yeah. So this is not for patients who have
This isn't for ablation?
No, this is not for ablation. This is for I-131 treatment, yes. So what are the pros of using this approach? Well, it's very simple. And this is how people have been doing it for many, many, many years, okay, about 70 years. So there's a long history of use, and in general, it's usually effective, and that's why they've been doing it. So those are some of the pros. What are the cons? So if you think about it, this approach is kind of a one-size-fits-all, right? So we're saying, we're not taking into kind of the individual characteristics of patient A and patient B. We're just saying patient A and B both have neck lymph node mets, so we're going to treat them with the same dose. So it's kind of a one-size-fits method. And what that may potentially do is you may be actually either under-treating the patient who may actually need more radioactive iodine, or you may actually be over-treating patients who actually may need less radioactive iodine. There's a study, it was a retrospective study that was published in 2006 where they kind of went back and calculated patients. Patients all got empiric doses, but then they had the data to calculate if we had not just done an empiric dose, but based it upon the patient's own characteristics, what would we have given them? And what they realized is, in general, what we ended up doing when we do empiric doses is for younger patients, you tended to under-treat them. And in older patients, you actually tended to overtreat them if you gave them empiric doses of radioactive iodine to treat metastatic disease. So then what's the other method that you could use to maybe more tailor the radioactive iodine dosages for the patient? That's going to be dosimetry-based dosage. I put this little, because it kind of reminds me of the Goldilocks and the Three Bears, right? Not too hot, not too cold, just right. So that's what we're aiming for, okay? What we're aiming for. I'm not saying that we get that right every time, but that's kind of what we're aiming for when we do dosimetry-based dosage. So this is going to be a dosage of radioactive iodine that's going to be individualized to the patients. And how do we individualize the dose to the patients? Well, we, number one, look at extent of the spread of cancer in the patient's body, and we also figure out how much radioactive iodine is the body taking up and how rapidly is the patient's body getting rid of the radioactive iodine. So those are some of the things that we're looking at. And there are actually even two different ways to do dosimetry-based dosage. It's lesion-based and whole body. So let me go over what those things are. So what is lesion-based dosimetry? So with lesion-based dosimetry, we'll have the patients get an I-131 scan or an I-123 scan, and we figure out, so here's an example of a real patient. So this patient here clearly has neck lymph nodes that have radioactive iodine. This is recurrent thyroid cancer. This patient had treatment previously. And so as a result, what you would do is you try to figure out how much radioactive iodine does this lymph node containing cancer take up, and based on that, figure out how much radiation do we need to put into this, metastatic thyroid cancer to get rid of it, basically. And like, for example, with neck lymph node metastases, we try to impart about 80 gray energy of radioactive iodine to that lesion to get rid of it. So this is what we call lesion-based dosimetry. It's basically the dose is based upon how much radioactive iodine is taken up by the areas with thyroid cancer, basically. Whole body dosimetry. So this is actually what we do at the University of Colorado, is whole body dosimetry. So with whole body dosimetry, we're not just looking individually at the areas of metastatic disease in the body. We're just kind of looking to see how much can the patient safely receive. So we call it's kind of a maximum safe dose of radioactive iodine. How much can they safely receive? And the idea is that we want to treat that thyroid cancer with the safest but highest dose of radioactive iodine with one-time shot, so that we don't have to keep repeating treatment. Because there is data out there, and we know that when you repeatedly treat metastatic thyroid cancer with radioactive iodine, you do it and then you do it again in 6 months, another 6 months, progressively, cancer is going to become less and less sensitive to treatment with radioactive iodine. And we know that's true, so then the idea is that let's just kind of treat it all at once while it's still sensitive with the highest dose possible so that we can get rid of it. So then what we do is we figure out, okay, so the dose-limiting organs are going to be organs that may be more sensitive to iodine treatment, and those the ones that we calculate are going to be the bone marrow as well as the lung. And basically what we do is using blood draws and with serial imaging, we figure out what's the clearance of radioactive iodine from this patient's body, because everybody has different rates of metabolism. They process iodine differently, and so we're trying to individualize the amount of radioactive iodine to a patient by looking at how rapidly they clear the radioactive iodine from their body. So let me give you an example. If a patient, we see that the radioactive iodine sticks around for a longer time in the body, whether it's because they have some sort of kidney problems or what have you, you don't want to give them a lot of radioactive iodine, right? Because whatever you give them sticks around in the body for a long time. So those patients would get less. But let's say the patient just rapidly excretes it from the body. In those patients, what you want to do is give them a higher dose, right? Because you know that the radioiodine doesn't stick around long enough to do its thing, so it's kind of rapidly being cleared. So those patients could tolerate a higher dose because the body is getting rid of it much faster. So those are kind of the things that we look at, and we do it by looking at blood draws. So this actually is a very committed procedure. Patients come to see us every single day for 5 days, so for an entire. So it's very committed procedure. So it's very time consuming. So they come back every day, and every day we draw their blood, okay, and they sit under our gamma camera and we take pictures. Okay, you don't have to swallow any more pills or anything like that, but you have to come back every day for blood draws and for a picture. So here's an example picture of one of our patients who got a 5-day dosimetry study, and this is this is not the blood, this is just the imaging that they got. And as you can see, day 1 through 5 here. So this is the first day. This is when the patient actually came in and swallowed 2 millicuries, a very, very low dose of radioactive iodine, I-131, and this is what they look like. And as you see, as the days progressively move on, what do you see? Kind of this hazy uptake in the body. You don't really see it on days 4 and 5. So this patient actually has pretty good clearance of radioactive iodine from their body. Okay, so this is kind of the pictures that we look at. Here's another example. This is an actual example of, what kind of what the study ends up being, basically. So the patients come back every day for blood draws and for imaging. So here's the imaging for this patient, days 1 through 5 here. And in addition to that, they do blood draws. And I don't have the graph here, but there will be a blood draw graph showing the amount of radioactive iodine in the blood. And then we also draw what we call a region of interest in the area of the lung, because we know that if patients have no metastatic cancer in the lungs, we want to make sure we don't cause any radiation damage to the lungs. So we also do special calculations for the lungs. So we do all this, and actually it's done by our medical physicist who does all the calculations for us. And then he sends us a report. So this goes to the nuclear medicine physicians and to our endocrinologists who are taking care of the patient, and we decide together what the dose of radioactive iodine we're going to give this patient is going to be. And in this patient, what we see is that, I'm sorry, the lettering is so small. So we look at what we call the blood threshold, which is the bone marrow, and the lung threshold. And in this patient, it ends up being that the limiting factor in giving them radioactive iodine is going to be their blood threshold. So in this patient, we can probably safely give them up to 250 millicuries, because that's how much their bone marrow may tolerate. Okay? So then, knowing this, when we decide how much we're going to give the patient, we'll be like, well, we're going to definitely stay under 250 millicuries. And I think this patient actually ended up getting 150 millicuries. Yes?
Is that in the lifetime?
What do you mean lifetime?
Is that like the maximum that they'll be ever?
Oh, no, that's a very good question. Thank you for bringing that up. No, it's going to be for this treatment.
Okay.
Not for lifetime, no.
So you can do
For
dosimetry every
Yes.
time?
So I think we've only had one patient so far in the last 2 years where we actually do 2 dosimetries. But in general, yes. So this data is for that treatment. It's not for a lifetime. Yes. Because when the patient comes back, it might be different.
Right.
Yeah. So then they come up with this report, and this is actually what we use to figure out what dosage you can safely give to the patient. Okay. So in summary, I-131 ablation, I want to reiterate, is use of radioactive iodine to destroy any remaining thyroid tissue after surgery, and usually those are going to be much lower doses of radioactive iodine. And in terms of determining who needs that radioactive iodine ablation, the key is going to be accurate risk assessment, okay? Because not everyone may benefit from I-131 ablation after a thyroid surgery, and data is showing that a low dose for I-131 ablation may be actually just as good as a higher dose. So this is actually something that is a controversial topic and people are working on, but I think we are kind of moving towards the fact that let's be more conservative about treating patients with radioactive iodine after surgery, as long as they're low risk, okay? And then I-131 treatment is using higher amounts of radioactivity to treat patients who have thyroid cancer that's gone to other parts of the body. So these patients need higher doses. And in order to figure out what their dose is, we still don't know what the best method is. We can do that fixed empiric dosage where we kind of, decide, based on the pattern of disease spread. Or the other option is that we try to individualize the dose of radioactive iodine by doing some sort of a dosimetry study to figure out what is the maximum amount of radioactive iodine that can be given to the patient safely. That's it. Thank you so much. And if you have any questions, please, at this point, we're going to discuss. Yes. That's a really good question. Okay. So even just 5 years ago, what they used to do, because sometimes what they see is that when they diagnostic scan with I-131 may not see anything. But actually, and because there weren't great treatment options, let's say 5 to 10 years ago, it was kind of what they call the Hail Mary pass, in football. So we were like, okay, let's just try. And so they give the patient a high dose of radioactive I-131 for treatment. And sometimes what we see is when those patients come back, you can see disease because you gave them a very high dose of I-131 that you didn't see when you did it with a lower dose of diagnostic imaging. But some studies, there was like a study that said actually in patients where you saw uptake on that high-dose treatment, the Hail Mary pass, the treatment, but you didn't see it on the diagnostic study, they weren't sure if those patients actually did any better. So but that's kind of controversial, but there are places sometimes that do that. But now the difference is, fast forward, 5-10 years, there actually is a lot more treatment options now available for patients who have metastatic thyroid cancer that no longer takes up radioactive iodine. So they would, for example, at the University of Colorado, we would prefer to put those patients on those drugs rather than just kind of give them a huge dose of iron-31 and kind of hope that some of the cancer actually takes up the radioactive iodine. But that's a very good question. Yes. Oh, yeah.
What's the most number of radioactive iodine treatments that a patient will under for metastatic?
Oh, who I've actually observed getting the treatment for. So this for me would be back in residency with a patient who had recurrent metastatic cancer. When I saw them, they were coming back in for their fourth dose. And the fourth dose would have been a cumulative dose, I think about 860 millicuries. So very high, yeah. But in general, most patients, that's very rare, very rare. I think last year, the highest we did was around 350 millicuries for a patient. And it was actually their first I-131 treatment. They already had the ablation, but it was their first treatment, and it was 350 millicuries. They actually got a whole body dosimetry study done. And actually, when we calculated, the safest amount they could get was actually 600 millicuries. But we are still like, oh, no, we're not giving 600. So we actually ended up giving the patient 350 millicuries. But the highest I've seen is cumulative dose of about 860. Yeah. Any other questions? Yes.
You haven't talked much about isolation afterwards. I'm actually set up for Wednesday. I might see you.
Oh, okay. Actually, if you're coming in Wednesday to the University of Colorado, you will definitely see me. Okay. Well, nice meeting you. Okay. You mean you were talking about safety precautions?
Yeah.
Oh, yes, I'm sorry. I didn't actually target this talk towards, kind of the whole process. I will be speaking to you in detail about it on Wednesday. Usually my consultations last anywhere between 30 minutes to an hour. Hopefully you won't be bored. But in terms of isolation for treatment, it depends. So, it used to be that when patients got treated with radioactive iodine, we made everybody stay at the hospital. Everybody. Whether it was for low dose, even if you got 15 millicuries for hyperthyroidism, or you're getting 100 for thyroid cancer, they all stayed at the hospital. But, we've talked about the fact that we've been treating patients for almost 70 years now. And what they realized was, that's really unnecessary. So that depending on the amount of radioactivity that is expected to be emitted from the patient's body, as long as if you go home and you're not going to expose others around you, then nowadays we pretty much send most patients home. Patients who we don't send home are patients who, for whatever reason, let's say their living situation doesn't allow them to do some of the isolation procedures, or patients who are getting very high doses for metastatic thyroid cancer. We know they're going to be emitting a lot of radioactivity from their body. So those patients actually get admitted and they stay with us. And even patients who get admitted, I'm going to mention the fact that for most patients, the amount of radioactivity in your body rapidly decreases. And patients really don't stay with us for more than 1 to 2 days after the treatment. All right, but those are the patients who will stay. And sometimes we have patients who can't maintain their bodily secretions where you have radioactivity. So those patients will also monitor for the first couple of days before it's safer for them to actually go home. But most patients actually stay home. And in terms of the radiation safety precautions, yeah, it is a 30-minute consultation. So we will go over that, but okay, thank you. Yes?
I have a question to do with isolation of children.
Yeah.
After my radiation in March, I had 2 milligrams.
Mm-hmm.
And I was going to visit my grandchildren.
Mm-hmm.
They were about 6 months and 2 years
Yep.
at that time.
Yep.
13 days after. So I got checked at the hospital and the thing was numbered. I had a very high level of radiation. So they told me to drink more and more fluids.
Mm-hmm.
And then I came back 5 days later and still had a very high level. So I was only allowed 1 hour contact a day for the next 2 weeks.
Mm-hmm.
And then I was allowed regular contact after that.
Okay. Now, when you were treated, were you treated as an inpatient in the hospital, or did
No,
you were sent home?
no, the first time on 200 I was in the hospital.
Oh, I was going to say, okay, yeah.
But I share an apartment with my son, who's the same out,
Yeah.
and they sent me home in September again.
Okay. Wait, so you're saying that after you got treated with 200, you actually stayed at the hospital
For 2 days.
for 2 days. But then when you came back 2 weeks later to be checked so you can see your grandchildren? No.
The third time is when I got tested again at the hospital twice.
Uh-huh. But did you stay at the...
They let me go home when I got 200 milliperiods again.
Okay, so what they're checking to determine whether a patient can go home or not. So the way we do it at the University of Colorado, and this is how it's done most places, we have to have documentation demonstrating that we have calculated how much radiation we're expecting to be emitted from your body. So when a patient is getting high, any sort of treatment above 30 millicuries, basically at our hospital and at most hospitals, all that information. So there's an interview. And then all the information about, who are you living with at home, how many bathrooms you have, and things like that. All that gets kind of inputted. And then we have actually not our medical physicist, but we also have a health physicist. And our health physicist actually will sit there and do the calculations. You're getting 200 millicuries, okay? How much do we expect, to be coming from your body at certain day? And so they'll do the calculations. So when they do the calculations demonstrate that, the amount of radiation that you're emitting from your body, so there's actually a legal limit of how much radiation exposure you can give to other people who are going to be in close proximity to you. And as long as you meet that limit, they'll send you home. Otherwise, they'll keep you at the hospital. And then at the hospital, how do we determine if you got treated as an inpatient when you can go home? They get the little meter and they measure you at like pretty much, at 3 meters and also further back at like 5. And they kind of detect how much radiation is coming from your body that way. And then when it's safe, they'll actually send you home. So,
Comment too, I was at the airport when I was flying.
oh, very good. Yep.
Customs asked me, do you have any medical problems? I've never had that happen before.
Mm-hmm.
So I said, well, I have thyroid cancer and I had radioactive iodine in September.
Mm-hmm.
So they sent me off to the PDR area,
Mm-hmm.
back,
Mhm.
customs, and they read my radiation level,
Mhm.
which said was able to high.
Mm-hmm.
But
How many-
I have a letter.
Yes, perfect.
saying I'm safe.
Perfect. Yes.
So then they cleared me.
Perfect. Yeah. So after the treatments, we give patients like a little card or a letter. We don't say exactly what you got because that's your personal information. We just say you've been treated, and so basically telling the people at the airport. So the places where they have the most sensitive radiation detectors are going to be the airport. Other places I had a patient who actually worked at a military base, so I was like, oh, make sure you carry your letter. And then also some places actually bridges will have it. Hospitals will have it as well. So I had a patient who came in after treatment for hyperthyroidism, and they just set off all the alarms in the emergency room because we have radiation detectors. But really, for most patients, where they're going to encounter sensitive radiation detection is going to be at the airport. So that's why we say carry your letter, and we say carry it for about 3 months. Because in general, the stuff comes out of your body very, very quickly, but depending on how sensitive that radiation detector is, it may be able to detect it. And there was a patient who only got 15 millicuries. 15 millicuries, very low dose for hyperthyroidism, not for cancer. And the patient went to the airport 8 weeks later, and they still detected it. So, but like I said, it's a very, very sensitive detector, and also it depends on how rapidly you clear the radioactive iodine from your body. So it can happen. So we tell patients just carry that letter with you. But in general, most of our patients, I've never had patients ever come back to me and say, I got stopped at the airport. But just in case, we say carry a letter. Yeah. Yes.
I still have my thyroid, but I had my third biopsy in a week with a perma test. I don't know what the result's been typical in the past 2.
Yeah.
In case I ever ran into this and had to have this radioactive iodine.
Yes, for ablation. Yep.
Yes, here's my question.
Yes.
I'm allergic to surgical iodine. Is that the same thing?
Oh, good question. So actually, in general, because we have kind of very nano trace amounts of radioactive iodine that's being used, even if you have iodine allergies to kind of the stuff you put on your body, right? You're not likely to develop a reaction because these are very, very tiny amounts, really, compared to the stuff that you're using, basically, like for the skin or something like that, for example.
And have you drink, use a big container of glass, and I think you can see them sometimes.
Yeah.
I've developed this is a mild allergy. I'm not having a breathing problem.
Yeah, so that would be a serious one. That'd be worried. Mm-hmm.
Itching, most of the skin where I have.
Yeah.
And I have had another test where they gave me for a heart deal. They gave me they insist on the iodine, but they give you some pills now. It took them a while to get it straight. They got up there and pretty well handle it. With some Benadryl and all. So this is different. You're saying this is different.
In general, the trace amounts of the iodine usually does not affect patients for the treatment, but it depends on your. I always say this, I speak from the perspective kind of broadly, but it really depends on the patients. And so this is a good discussion to have with your endocrinologist because they'll have to look at your medical, medical history and kind of look at you and see your other conditions and to figure out whether maybe you do need some sort of pre-treatment or something like that to reduce the risk of having a but in general for most patients the amounts are pretty trace, so that's not usually an issue.
It's doable.
Yeah, and who knows, you may be one of these low risk patients and they may decide that you may not need radioactive iodine ablation. So yeah, okay, yeah, you're welcome. Any other questions? Yes.
Can I ask you something from the talk? I listened to different doctors.
Yeah.
I have a surgery non-experienced doctor the first time. And then when I went to get my iodine test, they say I didn't respond to that. And now and later on I went to Mayo Clinic and I have extra surgery. But I wonder maybe, not that I did not respond to radiation, maybe I didn't have the first time good surgery that they can remove all the lymph nodes with cancer. That's why maybe. How you guys realize that some person doesn't respond to radiation?
So
To the iodine ablation.
okay, so to be honest, I'd have to see your medical records and kind of look at your pictures because I think what you're telling me is this. So you had thyroid cancer, so they took out your thyroid gland and you got radioactive iodine.
Yes.
How much radioactive iodine did you get?
125.
125. Okay, well, to be honest, it could have been for ablation, which would not have been ideal, but it could have been ablation, or maybe you had, do you know at the time of surgery, were there any lymph nodes that were positive in the neck?
2 lymph nodes. Yeah.
They did, okay. And then after you had the 125, they told you it didn't work?
Yes, because when I went, my thyroglobulin was higher than what I started with.
Oh, yes, that's why. Okay. So in that case, and how long afterwards did they check your thyroglobulin level to say it was high?
I don't remember.
You don't remember? Okay. So actually, basically what's going on here, this is what I'm gathering, is the fact that, yes, in general, if the radioactive iodine works and it distorts thyroid tissue and thyroid cancer, then you expect your thyroglobulin to drop. And when it doesn't drop, then you get worried that it doesn't work. But you also, I don't know what the time frame was between when you had the treatment and the thyroglobulin, but kind of as we discussed before, the thing with radioactive iodine is it only works if the thyroid cancer takes up the radioactive iodine. And the thyroid cancer, depending on what type of cancer it is, doesn't always take up radioactive iodine. So that could be an issue. And the other issue is sometimes it's hard for us to predict how much radioactive iodine is going to actually go to those areas and actually treat those areas or not. So, I mean, it doesn't happen often, but it could happen that patients need retreatment as a result of that because maybe the first time you didn't get enough radioactive iodine. But if the case is that it just no longer takes up radioactive iodine, then, radioactive iodine no longer becomes an option. And so, but it sounds like they went back in and took out the lymph nodes that were positive.
Yeah.
And then...
Can I have a second of 131,
Oh, you get a second treatment, okay?
Can I have one or? Is
Oh,
that a problem?
So it depends. So because I don't know your exact case, but if the reason they said that the I-131 didn't work the first time is because your thyroid cancer no longer was able to take up radioactive iodine, then no. But if the reason is that, so if they did a scan and saw that it still took up radioactive iodine, and maybe it didn't work because you didn't get enough of a dose, then potentially yes. So it really depends on that scenario. Do you still have thyroid cancer that accumulates radioactive iodine or not? Okay. Yes?
So say in a recurrence, this isn't me, but somebody, people in our group, and the whole body scan shows, that the lymph nodes are lining up. Is surgery in first preference? You wouldn't use IV treatment for lymph nodes over surgery?
So what do you mean by the first scan?
Oh, I'm saying if they have, they've had their thyroid out.
Yes.
And then
2
2 years later.
years later,
They have a whole body scan because their TG has gone up.
Yep.
And the lymph nodes light up.
Yep.
On that. Is not surgery the first choice for lymph nodes over? I mean, I've just heard that the radioactive iodine
Yeah.
goes into the lymph
So yes, so it really depends on the amount of cancer in the lymph nodes. So yes, if you have small lymph nodes, it may be that you just don't get enough radioactive iodine in there to treat it. So I'm sorry, I can't speak from a surgical perspective, but I know what you're talking about. So there are cases where if it looks like it's just in the neck lymph nodes, what they'll do is they'll go back and do a complete dissection and take out all the lymph nodes and see if that helps. But before they do that, what they'll usually do is either do a CT scan or they'll do some sort of an ultrasound to look for lymph nodes that look abnormal. And usually, yes, the first thing you'll do is if they can remove it surgically, they'll go back and actually do a more complete nodal dissection. In the case that I showed you on that patient with a recurrent cancer, that was really not an option because in addition to all those bulky nodes in the neck, there was all that disease in the lungs. Yeah, so by default of the fact that there was metastatic disease in the lungs, the patient actually did not get surgery. Yeah, and also with the surgery too, it depends on case-by-case scenario too, because sometimes surgery may not be a great option because let's say for whatever reason you had prior like beam radiation to the neck, maybe as a child for lymphoma or something, and you have a lot of scarring in that area, or you had some other surgery and there's just a lot of scarring. So if it's really difficult for the surgeons to go in there and dissect out the lymph nodes because of scarring or something like that in the neck, then instead of doing surgery, they may say, well, let's just do radioactive iodine because it's going to be a very difficult surgery, for example. So even then, like you actually have to have some sort of surgical evaluation to determine whether you're actually a good surgical candidate or not. And if you're not, they'll probably refer you to for I-131 treatment. So good question. Thank you.
Okay, now, I just want to say, you are very lucky. I wish my nuclear medicine physician had been like her. And I got very enlightened. I hope you all did. Right?
Thank you so much.
Thank you